Bismillahirrahmanirrahim. Good day, everyone. In this part of the talk, we will focus on hematologic consideration in kidney transplantation, specifically anemia and thrombocytopenia. This section is highlighting one of the most critical and challenging entities we encounter in this setting, thrombotic microangiopathy. We will walk through how and why it develops after kidney transplant, how it presents clinically, and why early recognition really matters for graft and patients' outcomes. I'm Dr. Mahmoud Sheikh, nephrology consultant and World Kidney Academy educator. Let's dive into part 2. Let's walk through the clinical presentation. This is a 54-year-old man with a history of focal segmental glomerulosclerosis who underwent diseased donor kidney transplant. His post-transplant course became complicated by progressive anemia and thrombocytopenia. He's receiving tacrolimus, mycophenolate, mofetil, and vanzaciclovir and TMP-SMX. And he received ATG for induction. Importantly, his tacrolimus trough levels are within the target range. Now, if you look closely at the labs, there is a clear downward trend in hemoglobin and platelet count over the first 2 weeks. At the same time, LDH is rising, haptoglobin dropping to undetectable levels, and the retic count is increasing. Creatinine initially improves, then begins to rise again. Taken together, this pattern points toward an active hemolytic process, rather than isolated drug-related bone marrow suppression. So now the key question becomes, which one of the following is the most appropriate next step? Option 1, perform a bone marrow biopsy. That might sound reasonable, especially with anemia and thrombocytopenia, but think about timing and think about what question you are actually trying to answer right now. Option 2, order IV iron. That's treat anemia a deficiency problem, but doesn't explain falling platelets and rising LDH and the undetectable haptoglobin. Option 3, obtain a peripheral blood smear. This is quick, non-invasive, and has the potential to immediately reveal what's happening at the microvascular level. Option 4, order a platelet transfusion. That might be necessary later if there is an active bleeding, but doesn't address the underlying process or risk making things worse. Before choosing, we are going to pause here and discuss these options together, and at the end of that discussion, we will come back and reveal the correct next step. Now let's shift to our focus to thrombocytopenia after transplantation. Starting with the definition. Thrombocytopenia is defined as platelet count below 150,000 per cubic millimeter. And this is not rare. In fact, it's quite common during the first year after kidney transplant, with roughly 2/3 of patients affected. Now let's talk about timing. Most kidney transplant recipients reach their lowest platelet count within the first 3 months after transplant. That time frame matters because it overlaps with the period of intense immunosuppression and heightened vulnerability to complications. So why does this happen? In the majority of cases, thrombocytopenia during this early period is driven by 2 main factors. First, induction therapy, and second, higher levels of maintenance immunosuppression. Both can suppress platelet production, increase platelet destruction, or unmask other underlying processes. And that's why when thrombocytopenia appears after transplant, we always need to ask whether this is expected and transient or just a signal of something more serious. Now let's recognize the major causes of thrombocytopenia after transplantation by timing and by the mechanism. Starting with early period within the first 14 days after transplant. Here, thrombocytopenia is most often related to ATG, post-surgical platelet consumption, or critical illness, or maybe HIT. In this window, low platelets are common and not always dangerous, but context is everything. Now moving beyond the first 2 weeks. Later thrombocytopenia is more often medication-related, including purine analogs like MMF or azathioprine, mTOR inhibitors such as sirolimus or everolimus, and even antivirals like vanzaciclovir. We can also see idiosyncratic reactions to antibiotics, and thrombocytopenia related to viral infections. But now, shift your attention to the right side of the table, because this is where things become high stakes. Thrombotic microangiopathy. This scan represents relapse or pre-existing TMA, often complement-mediated or de novo post-transplant TMA. Triggers include CNIs, mTOR inhibitors, or ischemia reperfusion injury, and maybe antibody-mediated rejection, and also infections such as CMV, parvovirus B19, or BK virus, even be caused by Chaga toxin-producing organism. And importantly, TMA may also reflect recurrence of autoimmune disease, including lupus or scleroderma, or even antiphospholipid antibody syndrome. So when thrombocytopenia appears after transplant, the key question is not just when it happened, but why, and whether this represents a reversible drug effect or microangiopathic process that threatens both graft and the patient in the same time. Now let's talk about drug-induced thrombocytopenia after kidney transplant. We will start with antisynthetase globulin, or ATG. It's one of the most significant contributors to early post-transplant thrombocytopenia. Many patients will experience a platelet drop, but only a small fraction fall below 50,000 per cubic millimeter. Next, vangacyclovir and ganciclovir. These agents can cause dose-dependent thrombocytopenia, especially when combined with other myelosuppressive medications. Now moving to CNIs, tacrolimus and cyclosporine rarely cause isolated thrombocytopenia, and when they do this, it's usually in the context of thrombotic microangiopathy, not simple bone marrow suppression. Going to mTOR inhibitors that are a different story, sirolimus and everolimus can lead to thrombocytopenia through direct bone marrow suppression, often in a dose-dependent manner. And finally, the purine analogs, mycophenolate and ethylpurine, can also cause dose-dependent thrombocytopenia, again through bone marrow suppression. So when platelets fall after transplant, the key is to decide whether this is an expected drug effect or a warning sign of something more dangerous, like thrombotic microangiopathy. Now let's talk about the scenario that really matters, concurrent anemia and thrombocytopenia after kidney transplant. In most patients, when anemia and thrombocytopenia occur together, they actually have separate causes for each. But that's not where we stop. When both appear at the same time, we must actively look for hemolysis. That means checking hemolysis markers, starting with haptoglobin, LDH, and the retic count, and the indirect bilirubin. If those markers point toward hemolysis, the next critical step is to examine a peripheral blood smear. We are looking specifically for schistocytes. Their presence is very important, but it raises concern for a thrombotic microangiopathy. But it's also essential to remember that schistocytes are suggestive, not diagnostic for TMA. So the smear doesn't end the evaluation, it guides it. And this is the moment where clinical judgment and lab strength and the transplant context all come together. Now let's focus on thrombotic microangiopathy. By definition, TMA represents a group of life-threatening conditions with different underlying mechanisms, but all sharing the same final common pathway. That pathway is thrombus formation within small blood vessels. Now let's walk through the pathophysiology step by step. First, thrombi form in the small vessels. As platelets are consumed at these sites, thrombocytopenia develops. At the same time, red blood cells collide with these microthrombi, leading to mechanical shearing. The result is schistocyte formation and intravascular hemolysis. This is what we refer to as microangiopathic hemolytic anemia. Now, an important clinical point. Systemic TMA can occasionally occur even in the absence of schistocytes on the peripheral blood smear. In some cases, the diagnosis may only become evident on tissue biopsy. So a normal smear doesn't completely exclude TMA, especially when the clinical picture fits. And this is why TMA remains a clinical diagnosis supported by data, not a single lab result. Now let's step back and look at how thrombotic microangiopathy syndromes are classified. Broadly, we divide TMA into primary and secondary syndromes, starting with primary TMAs. These are conditions where TMA itself is the core disease process. They include thrombotic thrombocytopenic purpura or TTP, typical hemolytic uremic syndrome, and atypical hemolytic uremic syndromes or AHUS. Now moving to secondary TMAs. Here, TMA develops in the setting of another condition rather than as a primary disorder. Common triggers include infection, organ transplantation, medications, and malignancies. We also see secondary TMA in pregnancy or malignant hypertension, or even in autoimmune disease. Now, here's the key takeaway. The distinction between primary and secondary TMA is not absolute. There is significant overlap between these categories, particularly in transplant patients, where underlying complement dysregulation can be masked by a secondary trigger. And that overlap is exactly where and why diagnosis and managing TMA can also be challenging and also very critical. Now, let's narrow this down to post-transplant thrombotic microangiopathy. Focusing on types and timing. First, recurrent atypical hemolytic uremic syndrome. This occurs when a patient has underlying AHUS, sometimes unrecognized, before transplantation. After transplant, the disease can reemerge, driven by dysregulation of the complement system. Now contrast that with de novo post-transplant TMA. This develops for the first time after transplantation, often triggered by events unique to the transplant setting, like ischemia reperfusion injury, CNIs, mTOR inhibitors, antibody-mediated rejections, or even infections. Now let's talk about timing, because timing is a major clue. Post-transplant TMA most commonly develops within the first 3 months after transplantation. Why? Because this is when patients are exposed to multiple complement-activating events, like high levels of immunosuppressive medications and also higher risk of infection. So when anemia, thrombocytopenia, and graft dysfunction appear early after transplant, TMA should always be high on the differential of your list. Now let's look at how post-transplant TMA actually presents clinically. There are two main patterns, systemic TMA and localized or renal-limited TMA. Starting with systemic TMA. This presentation is typically acute and classically involves a triad, thrombocytopenia, microangiopathic hemolytic anemia, and acute kidney injury. These patients often look sick. Their labs declare themselves early, and the diagnosis is usually apparent once hemolysis is recognized. Now contrast that with localized or renal-limited TMA. Here, the process is confirmed by biopsy, and patients may present with a picture of acute kidney injury or more commonly slowly progressive graft dysfunction. They may develop a new or worsening proteinuria and hypertension that becomes difficult to control. And here is the critical point. Renal-limited TMA may occur without hemolytic anemia and without thrombocytopenia. In these cases, the diagnosis cannot be made from blood tests alone and requires a kidney biopsy. So when graft functions decline and the usual explanation don't fit, renal-limited TMA must stay on the differential. Now let's look at what thrombotic microangiopathy actually looks like on kidney biopsy and how immunofluorescence helps confirm the diagnosis. Biopsy finding in TMA can be broadly divided into acute lesions and chronic lesions. Starting with the acute changes, one of the key features is intraluminal fibrin-rich thrombi, partially or completely occluding small vessels. We often see endothelial swelling, reflecting a direct endothelial injury. Within the capillaries, red blood cells becomes fragmented as they pass through these microthrombi, which mirrors the schistocytes we see on the peripheral smears. Mesangiolitis may be present, sometimes accompanied by microaneurysm formation, and the intramural fibrin deposition within arterioles. Now moving to the chronic changes. Here, the biopsy reflects ongoing or prior vascular injury. We see double contour formation along the peripheral capillary walls, hyaline deposits within arterioles, and progressive intimal thickening with concentric lamination. Now let's focus on the immunofluorescence image on the right. What stands out here is strong fibrinogen staining within the vascular structures, particularly the arterioles. This bright linear staining pattern represents fibrin-related material, highlighting active endothelial injury and thrombus formation. Importantly, this is not immune complex deposition. The staining localizes to vessel walls and lumens rather than showing a granular glomerular pattern, which supported the diagnosis of thrombotic microangiopathy rather than immune complex-mediated disease. In TMA, immunofluorescence is often negative for immunoglobulins and complements, but fibrinogen staining can be striking. So even when light microscopy findings are subtle, and even when schistocytes are absent in the blood, immunofluorescence can provide a decisive clue that this injury is vascular and thrombotic in nature. Let's walk through these images together, starting with the images on left side. Here at the glomerular level, you can see fibrin-rich thrombi located at the vascular pool and within the capillary lumen. On routine H&E staining, this fibrin appears as pink amorphous material, and on silver stains shows up as non-argiophilic material, confirming that this is fibrin, not basement membrane material. These deposits physically obstruct the capillary flow and represents one of the earliest lesions of acute thrombotic microangiopathy. Now shift your attention to the image on the right side. Here the arrows highlights glomerular capillary occlusion by fibrin material. You also notice areas of mesangial lysis where the normal mesangial matrix is dissolving, and the mesangial cells appear fragmented or even lost. In some regions, this structural breakdown progresses to microaneurysm formation, reflecting severe glomerular injury. These right-sided images show how microvascular thrombosis directly damage glomerular architecture. Now move your eyes to the image at the bottom. This is the vascular compartment. Here you can see fragmented red blood cells trapped within the vessel wall. The tissue level correlates of schistocytes seen in the peripheral smear. The arterioles show marked endothelial swelling, leading to luminal narrowing or complete occlusion. In the more severe examples, there is fibrin deposition within the arteriolar wall itself, sometimes accompanied by fibrinoid necrosis. This bottom image captures active and ongoing vascular injury and explains the abrupt decline in kidney function seen in acute TMA cases. So when you put all of these together, the left image have fibrin thrombi formation, and the right image have glomerular structural breakdown, and the bottom image have arteriolar injury and red cell fragmentations. This is acute thrombotic microangiopathy on biopsy driven by endothelial injury, platelet-rich thrombosis, and mechanical hemolysis. Now let's move to the chronic changes of thrombotic microangiopathy. Start with the image on the top left. Here you are looking at arterioles with marked concentric intimal thickening, what we often describe as onion scanning. The vessel wall is progressively thickened by layers of fibrosis, leading to severe luminal narrowing. This reflects repeated or ongoing endothelial injury over time, not an acute event. Now shift your attention to the image on the top right. At the glomerular level, you can see features of chronic ischemic changes, like damage. There is segmental sclerosis with areas of capsular adhesions, highlighted on trichrome stain. You will also notice cellular interposition within the capillary walls. A response to chronic endothelial injury and subendothelial expansion. These findings explain why chronic TMA often present as slowly progressive graft dysfunction, rather than an abrupt decline. Now move your eyes to the image at the bottom. There highlights chronic glomerular ischemic changes. On silver stain, the glomerular tuft appears relented and collapsed, a classic ischemic pattern. And on H&A, you can see a relative bloodless glomerulus with mesangial collapse. And most importantly, on higher magnification silver stain, you'll see double contour formation along the capillary walls. These duplicated basement membranes are the histologic footprint of chronic endothelial injury and repair. So when you put all of these together, the top of left shows chronic arteriolar remodeling, and top right shows chronic glomerular scarring, and the bottom image shows ischemia and basement membrane duplication. This is chronic thrombotic microangiopathy on biopsy, a record of past vascular injury, often irreversible and closely linked to long-term graft dysfunction. Now let's focus on the causes of de novo post-transplant thrombotic microangiopathy, and we walk through them one by one. Start with number one, on the top left, complement activation. Activation of the complement system can occur very early in the post-transplant period. This risk is higher when kidneys come brain-dead donors, when the donor is brain-dead donor, likely related to prolonged warm ischemia time, which amplifies complement activation and secondary endothelial injury. So in some patients, transplantation itself becomes the trigger that unmasks a complement-driven process. Now move to number 2 on the top right, drug-induced TMA. This is the most commonly associated with CNIs, specifically tacrolimus and cyclosporine. The proposed mechanism is a loss of normal balance between vasodilatory and vasoconstrictive mediators, leading to endothelial dysfunction and microvascular injury. Importantly, more than 95% of transplant recipients receive these drugs, yet only a small fraction develop TMA. That tells us additional predisposing factors must be present. Now shift your attention to number 3 on the bottom left, antibody-mediated rejection. Here are donor-specific antibodies bind to HLA antigens on the allograft endothelium, activating the classic complement pathway. This can spill over into alternative pathway activation, causing cell lysis, inflammatory infiltration, and microvascular thrombosis. Patients who develop TMA in the setting of antibody-mediated rejection have significantly worse graft survival. And finally, look at number 4 at the bottom right. Viral infections. Among these, CMV is the most common. CMV has direct thrombosis for endothelial cells, promoting platelet adhesions and microvascular thrombosis, which can directly trigger TMA. So when de novo TMA develops after transplant, it's rarely due to a single factor. Instead, it's often the convergence of complement activation, drug exposure, immune injury, and even infection. And all of this on top of vulnerable endothelium. This figure summarizes the mechanism of post-transplant immunosuppressive agents, and understanding this layout is essential when we are forced to change therapy in the setting of drug-induced TMA. Start at the top of the diagram. Here you see the antigen-presenting cell interacting with the T cell through the MHC-T cell receptor complex with an additional co-stimulatory signal. On the left side, this co-stimulatory pathway is blocked by belatacept. Belatacept inhibitors CD80, CD86 signaling, preventing faulty cell activation without exposing the endothelium to CNI-mediated toxicity. Now look just below that, still on the left side. Here are the CNIs, tacrolimus and cyclosporine. These agents block interleukin-2 transcription by inhibiting the calcineurin pathway. But in susceptible patients, they disturb the endothelial hemostasis and can directly precipitate TMA. That's why when TMA is suspected, these drugs are usually the first to be reduced or withdrawn. Now shift your attention to the center. Interleukin-2 is the key signal driving T cell proliferation. Blocking this signal at different levels is how we maintain immunosuppression after stopping a CNI. Move your eyes to the upper right. Here you see interleukin-2 receptor blockade with basiliximab. This is often used during induction or as a temporary strategy while maintenance immunosuppression is being restructured. Just below that, on the right side, is the mTOR pathway. mTOR inhibitors, sirolimus and everolimus, block downstream proliferation, but they can also impair endothelial repair and in sometimes cases worse in TMA. So switching from CNI to mTOR inhibitors is not always a safe solution. Now look at the bottom center. Here are the anti-metabolites, mycophenolate, mofetil, and ethioprine. They suppress T cell proliferation without directly injuring the endothelium, making them relatively safer backbone in patients with TMA. Finally, at the bottom of the diagram, you will see T cell depleting therapies. These include ATG and CD52 blockade with alemtuzumab. These agents are typically used for induction or high immunological risk patients and may be incorporated selectively when maintenance options are limited. So when managing drug-induced TMA, the goal is not simply to stop a medication, but to rebuild immunosuppression in a way that protects the graft while removing endothelial stress. And this diagram explains exactly how we do that. Now let's put everything together and talk about treatment strategies for post-transplant thrombotic microangiopathy. Start with the panel on the left, drug-induced TMA. The very first step is to reduce or replace the offending agents. In practice, this often means switching tacrolimus to cyclosporine, or vice versa. Another option is switching to a different drug class, such as an mTOR inhibitor, although this approach remains controversial. In selected patients, particularly those who are EBV seropositive, conversion to abelatacept may be considered. But it's important to recognize that effectiveness of switching immunosuppression is not uniform, and some studies show no clear difference in outcomes. Now move to middle panel, belatacept consideration. Belatacept is CTLA for immunoglobulin fusion protein that blocks T cell co-stimulation. One major advantage is that it carries no direct risk of TMA. However, this benefit comes with trade-offs. Belatacept is associated with high risk of acute rejection compared with standard CNI-based therapy. And this is contraindicated in EBV seronegative patients due to markedly increased risk of PTLD. So belatacept is not a default choice, a strategic decision made in carefully selected patients. Now shift your attention to the panel on the right, TMA associated with antibody-mediated rejection. Here, the mainstay of therapy is plasma exchange, with or without IVIG, along with intensified immunosuppression medication. In refractory cases where hemolysis persists despite maximal conventional therapy, eculizumab may be considered. But it's not the first line of therapy. Eculizumab is reserved for a rescue treatment, rescue therapy, or for severe or persistent disease, particularly when complement activation is driving the process. So the key takeaway is this treatment of post-transplant TMA is not one-size-fits-all. It depends on the underlying mechanism, drug exposure, immune injury, and patient-specific risk. And choosing the right strategy can make the difference between graft recovery and graft loss. Now let's close the loop on the case. The correct answer is option C, to obtain a peripheral blood smear. Here is why the patient presents with concurrent anemia and thrombocytopenia, along with lab evidence of hemolysis. LDH is elevated, haptoglobin is low, and the retic count is increased. That constellation of findings raised strong concern of thrombotic microangiopathy. A peripheral blood smear, while not diagnostic on its own, as we mentioned before, is a critical next step, because the presence of schistocytes will strongly support a microangiopathic process. Now let's briefly address why the other options are incorrect. Platelet transfusion is generally avoided in TMA unless there is life-threatening bleeding, because it can worsen microvascular thrombosis. A bone marrow biopsy doesn't help in the acute evaluation of suspected TMA and delay more relevant testing. And IV iron is not indicated here. This patient has hemolysis, not iron deficiency. So in a post-transplant patient with anemia, thrombocytopenia, and hemolysis, the peripheral blood smear is not something in a site. It is the most appropriate next step, and that simple decision sets the entire diagnostic pathway in motion. Thank you very much for your time and attention. I hope this session helped clarify the hematologic challenges we face after kidney transplantation, specifically thrombotic microangiopathy, and how early recognition can truly change its outcome. If you would like to stay connected, you can find me on X at this handle shown on the screen, and through Nephromed YouTube channel, where I regularly share online nephrology education, clinical updates, and practical insights. You are also very welcome to join our Nephromed Fellowship group on Telegram, where we discuss cases, review core concepts, and support each other through training and practice. The QR codes on this slide will take you directly to our platforms, including YouTube, Facebook, and WhatsApp, and X, and Telegram. Once again, thank you for being here. It's happy to take any questions or any comments, and thank you so much. Thank you.